to the next discussion. Now we move on to the next discussion. It's a panel discussion on a very important and complex topic, that is the hyperferritinemic sepsis. And to take us through this discussion, I'll just introduce the panel. The panel is first by Dr. Saroj Prushty, sir. He is the head of department critical care at Virinchi Hospitals, Hyderabad. Sir. Next is Dr. Anand Joshi, sir. He is the consultant intensivist and physician at intensivist at Campbelltown Hospital, Sydney, and also the ICU physician at government hospitals. And Dr. Madhusudhan R Jaju, sir. He is the head critical care medicine, Yashoda Hospital, Secunderabad, and the past EC and treasurer of ICCM, Hyderabad. And to guide us and take us through this topic would be Dr. Srinivas Jakkinaboina, sir. He is the head of department and critical care and medical director at Sri Sigma Hospitals, Hyderabad. I hand over the chair. Yeah, thank you.
Thank you and good afternoon to all. Today we have a topic almost like a trending topic. Now wherever we go, we are on discussing on hyperferritinemic sepsis. It's a complicated topic. And first I thank critic organizers for having our hyperferritinemic sepsis team here on this. So we all know ferritin we are doing this test from the last 50 years. One of the most common tests done in a medical college or in the hospital. And this is about like it controls iron, because iron also is harmful for the excess of iron is harmful for this. And also it's an inflammatory marker. Let's look into this. First we'll go through the case presentation quickly. First we'll go through quickly. A 30-year-old software engineer came to emergency room with high-grade fever, weakness, swelling of feet with rash since 4 days. He was evaluated for infectious disease outside, which was negative, and he had a similar episodes of fever in last 2 months. He used various antibiotics. This patient is tachypneic, tachycardic, febrile, lymph nodes are not palpable, and rash over the perioral legs, hands will show the swelling, facial swelling, and subconjunctival bleeding is there. So this is about the patient we see, and this patient. Okay, so WBC is elevated and the platelets are down, and it is further came down, and creatinine is a multi-organ failure. Basically, it's creatinine is high, liver enzymes are elevated, ABG shows metabolic acidosis, X-ray was normal, NIV was started in this patient. Skin biopsy, tissue culture was done, blood cultures were negative, PCT was high, CRP was high, and we have done workup for the other diseases which are negative. Echo is normal, ultrasound is normal. Here the ferritin is 28,760. CSF is not done because of low platelets, 60,000, and BMA was normal to hypercellular. Now I ask Dr. Madhu, what is the role of ferritin in ICU?
Good morning to everyone. I think first we should thank to the organizers for bringing this topic, as Srinivas also told. It's quite important topic. A lot of confusion is there for the people. I think at the end of the 20 or 30 minutes, a lot of things will be clarified. The ferritin in the ICU is not a routine investigations we do. Normally, when the patient becoming sick because of the various reasons, we do the organ-specific investigations are there. Either the predominant, which is the organ got affected, either the genitourinary tract, hepatobiliary, or respiratory tract, or anything else is there for the cardiac, we do specific investigations. Particularly when the patients are quite sick is there for the patient, we done all the investigations for the patient. That time it is showing multi-organ failure. We have find out for the patient having liver dysfunction, kidney dysfunction is there for the patient having a bicytopenia, and as a part of the evaluation, as last case was told about DIC for the patient, that time we think we have something else we are dealing for the patient. That is the time we do an investigation for the ferritin. And after doing ferritin, is the important about the what is the level of the ferritin. At the single level of the ferritin is not important. We have to see the trend. As we are seeing the trend for the various things are there for the patient. Either we are doing CRP or PCT or TLC, we see the trend. In the same way, when we do ferritin, the trend is important. As we know about normal value of ferritins in a male and female, particularly male 20 to 300 milligram per deciliter, and a female about 20 to 150 milligram per deciliter. So that whenever the levels are more than 500 is there, you should be some giving warning. But when the levels are increasing drastically for the patient, that is then giving a more implication for you. So that in nutshell, when we are thinking about multiple organ problems are there, particularly for the patient, bicytopenia, liver dysfunction, kidney dysfunction, or the other things are there for the patient, hyperfibrotism with hypertriglyceridemia, that is the time we ask for the ferritin level in the ICU.
Thank you, Madhu. And any few one or two additions from Anand and Prushti, anything from you?
Yeah. So, as Dr. Madhusudhan told, we don't think of ferritin regularly, only certain situations, case scenarios where either existing patient in the ICU or a new patient has come to the ICU. So if it is existing patient in the ICU, patient is worsening and patient is going towards organ dysfunction and patient's fever is not coming down, patient is showing signs of either pancytopenia or bicytopenia. So these are the situations where, or if you are thinking that underlying some autoimmune disease or some other rheumatological disease or some other conditions are there, which are comes as a differential diagnosis for hyperferritinemia, there we are thinking of doing an ferritin in the ICU.
Just two things to add. Ferritin, like an acute phase reactant, so it will be elevated. In subsequent thing, we will try to evaluate, as Madhu said, levels are very important. Second thing, um, when you're thinking your differential um, in an intensive care beyond regular sepsis, there is a investigation and there is a clinical dissociation. Patient looks sick, but rest of the things, investigation doesn't look that sick. That's when I think these smaller tests, which are going to narrow down your differential, will come into help. Specifically here, we are looking at dreaded conditions pertaining to intensive care would be HLH and few malignancies.
We'll go into the detailed discussion. Dr. Prushti, the ferritin is elevated in the ICU when in the similar patient, 27,000 we showed. So what is your differential diagnosis? What comes into your mind?
So basically the acutely ill patients, when your ferritin levels are so high, that too in this case you saw that patient ferritin level was 28,000. So it is very high because as Dr. Madhu told, more than 300 in a male patient is significant, and that too it is 28,000. So here we have 5 to 6 conditions where acutely ill patients where ferritin levels will be very high. So either you think of a macrophage activation syndrome or a HLH, means or a patient is having multi-system inflammatory syndrome, particularly related to COVID in adults, or a patient is having adult onset Still's disease, where you will get so much of ferritin very high, or a patient is having juvenile arthritis. So these are the conditions where your ferritin will be very high. Sometimes you see that acute excessive alcohol consumption or a viral hepatitis patient where there is a hepatocellular injury, we'll see high level of ferritin which are coming to the ICU. Patients are coming to the ICU. Besides acutely ill patients, some other conditions your ferritin levels will be high, but not up to the 28,000. Those are, you can divide the things into like 3 categories. The ferritin where you are with our increased ferritin with iron overload, increased ferritin without iron overload, and increased ferritin with or without iron overload. So increased ferritin with iron overload, either 2 or 3 conditions, like you think of familial hemochromatosis or a iatrogenic iron overload condition, multiple blood transfusions, or a iron overload anemia. So these are the conditions where you will get with iron overload. Another conditions where with or without iron overload, either a CLD or CKD patients, means chronic liver disease patients, you will get a with or without iron overload. With hyperferritinemia, without hyperferritinemia, most of the your that acutely ill patients coming to that without iron overload conditions, as we have described. Along with that, some autoimmune conditions and rheumatological conditions also comes under this category. So
Okay, let's
that's
go into the Dr. Anand. How do you investigate in the above conditions? He discussed about many conditions. So whether iron overload, no iron overload. or only isolated ferritin elevated? How will you investigate in the above
Yeah, so
condition?
as for any physician, we start with historical with the history. So any patient who's got the history which would suggest me that there is an iron overload state or metabolic syndrome, that will give me a caution. Second thing, once the patient is in ICU as this patient, and if I have this high ferritin level, then my subsequent investigation will be focused on ruling out the differentials, which just now what Saroj said. Always I start with the basic CBC, look for the white cell count, look for the differential counts, look for the liver cell failure, and also look for the various organism sepsis, viral infections. All those investigations would be an important, particularly addition of the CRP and the procalcitonin, in which would be helpful for me whenever I'm dealing with this kind of infection. Third thing, non-infectious cause should also be kept in mind. The broadly speaking, my approach will be to differentiate the most lethal differential to the less lethal differential. To categorize that, I will categorize whether I'm dealing with HLH or not, because its investigation and its approach will be different, for which hyperlipidemia is there and other classification, other parameters are there for HLH. For a non-HLH, it will be whether septic or non-septic, and in non-septic, whether I'm dealing with a liver failure issues or hematological malignancy. And this is how I will continue to investigate.
Yeah, Dr. Prushty, you want any additions in this?
So as Dr. Anand told that regarding the critical ill patients, you need to look for these conditions where you need to evaluate, come to a diagnosis that whether patient is fitting into those categories. And non-critical ill patients, those who are coming to you want to, all your differential diagnosis you want to rule out. Like you can do initially transparent saturation. So if you are transparent, because to rule out a iron overload condition, if you do a transparent saturation, if it is more than 45%, it means that patient is having iron overload condition. With anemia or without anemia, do a genetic study and confirm the diagnosis. Another condition where your transferrin saturation is less is without iron overload. Do and liver enzymes. The liver enzymes are high, goes in favor of excessive alcohol or viral hepatitis. And the conditions where your inflammatory markers are high, but liver enzymes are normal. In those conditions where your all acutely ill patients will come. Like if CRP is high, your procalcitonin is high, ferritin is also high, and your liver enzymes is normal. So in that condition where you will get all these HLH, macrophage activation syndrome, adult ancestral disease, means all these conditions will come. So in this way, and then again etiological diagnosis. When you are thinking of HLH, again you need to evaluate depending on the etiology. So most of the time, either it is a infective pathology or a hematological malignancies. So for infective pathology, again you need to do different viral markers, and whether it is a bacterial, what type of viruses usually it causes, either Epstein-Barr viruses, cytomegalovirus, adenovirus, or a herpes simplex virus, or a Ebola virus, or a dengue virus, what type of virus. These are the common viruses which causes HLH.
Yeah.
So
Yeah, Dr. Madhu, you want in this bone marrow was done
Yes,
and
yes. Actually,
skin biopsy was done and CSF was not done because of, is it all required necessary?
yes. Actually, as I told about whenever the cases comes, particularly in the ICU, we should differentiate about infective versus non-infective is there. The patient having autoimmune or some malignancy. If you have these broad terminologies are there, what Dr. Prushti and Dr. Anand told, that is important. Another important thing is there for these patients, particularly you have to take the precautions properly. And if you have high degree of suspicion is there of involvement of the CNS also, with the cover of the antiplatelets, other medication safe is there, we should do definitely CSF. Because the prognosis, if you are not doing for the CSF, the prognosis is quite bad. Some of the HLS cases with involvement of CNS, we have the problems, or some occult malignancies also. And the bone marrow is important when you are doing for all these cases. We are not able to come to the conclusion with multiple if the patient having bicytopenia is there, definitely we should do bone marrow and along with the cultures. In that, sometimes we are not able to pick up the organisms in the routine cultures, everything bone marrow is able to pick up. And in the question about hemophagocytosis, we are able to demonstrate only 30% of the cases. So high degree of suspicion is very important for these cases of patient. So the reason this series of investigations we have to do to come to the conclusion, and we have narrowed down the differential diagnosis for the patient.
Yeah, thank you. And actually, this patient is suffering with fever since last 2 months, as I mentioned. So he's going to various hospitals, getting investigated. He has landed in emergency because he's presented with breathlessness, and so that's the reason why he shocked. So that's the reason why he landed. Otherwise, he should have not. He was investigated and giving on antibiotics since last 2 months. So there are diseases like Still's disease already mentioned. Here, one of the clue is like ferritin will be very more than 5 times higher, but the CRP will not be more than 5 times higher. And there are criteria for this, and this patient fits into most of the things. And hemophagocytic syndrome, HLH, he has already mentioned that. So, what is the role of ferritin in sepsis? Because what we do in sepsis is as soon as the patient comes, we do a CRP and a procalcitonin and any other markers, WBC, these things we look into it. What is the role of ferritin in sepsis? And yeah,
The ferritin, when you are doing, particularly as we discussed, when you are sending the ferritin, the level is important. Single value will not give the idea for you, but regularly you are following up the value. Suppose you are seeing the value is increasing for the patient 3000 to 5000, patient is stable, is not much significant. To the same level, if 3000 to going to 10,000 for the patient, along with if you are seeing LDH is going for somewhere between 300 to 500, we see about SGOT is there which increasing from 100 to 150. Patient is quite sick, hemodynamically unstable patient is there. That definitely will give an idea about something happening for the HLS for the patient. The reason single value is not important. Along with clinical condition of the patient and what routine investigations we are sending, along with that we are doing interpretation of the ferritin. So that when the ferritin level is quite high, more than 10,000, 30,000 is there for the patient, as in this case is there, definitely.
Mike, give me.
Hello.
Uh,
So that when the level is increasing more than 10,000 to 30,000 is there, along with clinical condition of the patient is quite sick, requiring multiple doses of vasopressors is for the patient. We have altered liver function, kidney function is there for the patient. The definitely patient going to HLH. So that is the idea for seeing the doing the ferritin and monitoring the level of the ferritin.
okay. Any additions from you, Dr.
Yeah.
Prushti and
So
Anand?
here also, as Dr. Madhu told, I want to add some more point related to sepsis. It is ferritinemia, increased ferritin level in sepsis and non-septic patients is also important from the management point of view. So when ferritin levels are very high, and present, it means that that is the immunomodulatory effect. So in this highly inflammatory condition, so in this case usually we need a anti-inflammatory drugs. Either you go for IVIG or you need to give a high dose of steroid, which helps for the management of the patients. Where you see a macrophage activation syndrome, where you will see most of this only as a ferritin level will be very high. Along with other organ dysfunction is there, and your non-septic condition where ferritin level will be high, like your autoimmune disease or a rheumatological disease. In that situation, only anti-inflammatory will work. Whereas in HLH, where you are secondary to sepsis or hematological malignancy, you need to give a immunosuppressant drug. So addition of a etoposide or a cyclosporine along with your high dose steroid or IVIG, so will be helpful in HLH patients. Whereas in autoimmune disease patients or a rheumatological disease patients, only anti-inflammatory drug or with cytokine storm, if it is there, you can add an interleukin 1 inhibitor like anakinra, so which helps in managing the patients. So we need to, for that reason, we need to differentiate between sepsis and non-septic patients.
Okay,
So
any
basically, so when the role of ferritin in a sepsis will be to, for a deteriorating patient with cauda multi-organ failure, um, it will be whether the confounding other uh, differentials are there along with the sepsis, which are complicating the situation, particularly whether the sepsis is complicated by HLH or liver failure or any associated malignancy or cytokine storm, that would help us to add, along with our routine regular sepsis management, add any immunosuppressants or any other immunomodulatory drugs.
Thank you.
Important when we are saying ferritin, high level of ferritin is that macrophage activation is there. And once we are seeing macrophage activation, very high incidence of chances of mortality and getting complication for the patient. That one thing we can understood when the level of ferritin is very high.
So, what is the role of ferritin in non-sepsis? We have discussed just yeah, non-sepsis, and so we commonly do CRP and procalcitonin in sepsis. So, even a patient comes, do you recommend now right now to do a ferritin and give steroids or immunosuppression if it is high? How do you go ahead? Because I wanted this from all of you.
So this is a very tricky situation. So the way I would approach is, if my procalcitonin and CRP is not able to answer my clinical condition, I don't have any bacterial cultures coming positive, the PCT is modestly raised, but the patient is going in many in multi-organ failure. Along with that, I do know historically his liver was okay, his kidneys were okay, but now the patient is in a multi-organ failure that cannot be explained solely on the basis of sepsis. That's when probably my ferritin levels will help. Given the ferritin levels going beyond 30,000, 40,000 will help that my sepsis or my patient has got a secondary HLH, or there is a severe cytokine storm that is happening, and that's where my immunomodulation will occur. This will also prompt me to evaluate for other non-routine viruses, whether it's a dengue, whether it's a COVID, whether it's an associated any other Epstein-Barr virus. Those things will also be taken into consideration depending upon the ferritin levels.
Actually, these are the all acute phase reactants. Whether you talk about CRP, ferritin, all things are there. And particularly in the clinical situations, what we can see, particularly when the autoimmune diseases are there, which are causing a flare up. And when we want to give, as Prushty told, the two things are important: whether immunosuppressants we are going to add, or we are going to add the immunomodulators for the patient. That time, if you understand, if the flare up is there because of the autoimmune disease are there, where CRP is increased for the patient, and when PCT will give more of negative predictive value of not of gram-negative infection, that will be much more useful for deciding on the treatment, whether we are giving an antibiotics are there or immunosuppressants or immunomodulators for the patient. In addition, ferritin will be increased in all the cases what we are seeing about the patients of trauma, post-operative, burns patients are there, or we have done multiple blood transfusion because of acute phase reactant. So that if he is not elevated, we can use more of a negative predictor value than a positive. If you are thinking ferritin is elevated, as we discussed the previously, the value is important and the trend is important. Otherwise, we can use more of a negative predictive value in cases of sepsis or to rule out than the rule in for the patient for utilizing the ferritin level.
Yeah, that would frustrate. So basically, most of these patients present with some other diseases in the background. Suppose this patient has a Still's disease and they presented with multi-organ failure. How you like what are the as these with markers? How will you go ahead, Dr. Prushti?
Yeah, that's what. So here, how it will help
This
in,
patient comes first day into emergency.
yeah,
So how will you proceed?
yeah. So coming to emergency to the ICU and initial evaluation. So when we are thinking of a critical ill patient, then these are you are thinking of these conditions, and HLH is the primary diagnosis. So definitely that time ferritin is helpful for us for the diagnosis. To know secondary infections, whether it is a bacterial infection or a viral infection or a fungal infection, again we do CRP and Procal. But we don't stop at there. Again, we look at the trends. So for the after the diagnosis is clear, you reached the diagnosis of HLH and you started managing with immunosuppressants and with the antibacterials. And whether patient is deteriorating further or improving further, we need to stop the treatment there, and which drug need to be stopped, we need to take a decision. So how these biomarkers are helpful to us during the therapy? Suppose patients, you just imagine that patients ferritin levels are coming down, and whereas C-reactive protein and procalcitonins are going rise. So it means that patient's immunosuppressant effect is worsening and patient's secondary infections are becoming more. So we need to stop immunosuppressants there, and we need to add or change the antibiotics to a stronger antibacterial and or may need to add an antifungal agent because patient is having a worsening sepsis. Because this trends of value is important, as Dr. Madhu told. And if the scenario is different where your C-reactive protein and procalcitonin levels are decreasing, improving, and ferritin level is worsening, means patient is having an underlying disease is worsening. So in that case, you need to modulate your immunosuppressant effect or immunomodulator. So we need to increase or change the therapy depending on the underlying disease.
Yeah, I mean that when to do ICU, I think you should have already covered that basically.
Yeah.
So basically, you have to any additions you want to do, when to do in
Nothing.
ICU?
Just because all are critical care people, what we can
Mm.
say about the sepsis rule guidelines are given about what are the targets of 1 hour, 3 hour, 6 hour targets are there. We even after 24 hours, after doing all the resuscitation for the patient, appropriate medications, still we are not going forward. Something else is there. I think that is the time you think about sending the ferritin. One. Sometimes patient being referred from the outside hospital with all the investigations are there. Patient having bicytopenia, impaired liver kidney dysfunction is there for the patient. Patients have hemodynamically unstable is there for the patient. That time also we can think about sending the ferritin for the patient. And when appropriate treatment given for the patient, in spite of that, we are not understanding. I think these are the 2 or 3 conditions. This is not the routine investigation we are going to send in the ICU along with the CBP, RFT, LFT. When you are not things fitting in the particular syndrome, particularly criteria what are treating for the patient, once you rule out taken care of bacterial, viral, all things are there. That is the thing we should send ferritin,
Yes.
not as a routine.
So that would be to suggest simplistically, ferritin will always be an add-on supportive investigation which you won't be doing on the first blood sample. Uh, with a high index of suspicions, when there is your investigations and your clinical conditions are not correlating, and you have to think out of box whether there is an add-on confounding problems which probably has been missed. That's when you would get the ferritin levels.
Yeah. Yes, actually, you don't go on do now. Tomorrow, we had a topic on hyperferritinemia. Do a ferritin. Ferritin will be elevated anyway, and giving cyclophosphamide, steroids, okay, and plasma exchanges. Please don't do it. You resuscitate your patient, okay? How you resuscitate your patient in a regularly with whatever you do, whether hemodynamics or lung wise or markers wise, you continue your work, okay? Suppose patient is not improving or something is going wrong, whether you don't look like a something background disease is there or that some sepsis is there or some other condition. So at that time you start working upon ferritin. In this explained patient also we have done serum ferritin on the third day. So because most of the investigations were done, cultures are negative and all these things. So at that moment, then we had done his ferritin levels and it was high. Actually, this patient should have worked up outside in a because this patient already has 2 months onwards, he's continuously having fever. I think 6 or 7 regimens of antibiotics he has used. So I think he should have worked up previously. So let's go into the few of the evidence based slides for the next 2 minutes. So this is about this is a data which was published in 2020. So this is in the critical care unit, 18 more than 18-year patient. They have taken hyperferritinemia as a more than 500. So they have looked into the HLH patients. They had around 40 out of 2,623. So they have looked into this data and they have analyzed it that it is more than 9,000 and less than 9,000 ferritin. So here if you see into the age, more than 9,000 age is less and here ferritin is very high. The significant factors I'm telling, more shock in ferritin levels, hyperferritinemia and hepatitis is there and in hyperferritinemia patients. And in this, CRP also is high, procalcitonin is high, lactate is high, LDH is high, and temperature is high. And these patients underwent more hemodialysis, and they have a maximum SOFA score at admission is higher. And these are sick patients. ICU duration was high, inpatient duration was high. and also mortality is high. So this patient looks absolutely like a sepsis and septic shock patients. Only we need to identify and rule out of box thinking. And these patients basically again they have underlying diseases on the maximum ferritin they have looked into. So they had one is septic shock. Septic shock, as we all know, it is not a disease, so it's a is a cause for some other things. So when it comes to the diseases, he looked into the one is liver disease and malignancies. These are the two things they looked into. They found that there is highest thing. And if you in these liver disease and hematological malignancies, they again looked into the subgroup analysis. They found that acute on subacute liver failure, these are the patients who has a higher ferritin levels, and pre-existing immunosuppression, high urgency liver transplantation, which is normal. And only in acute or subacute liver diseases, encephalopathy is not significant, and hepatic veno-occlusive diseases, they found ferritin is higher. And also AML patients they found higher, and Kaposi's sarcoma, and they trend towards the aplastic anemia. These are the conditions where they found that the ferritin is high. And I think we'll take one or two questions. Thank you. Any other opinions from experts here or any contributions? We have almost time up. Request you to give 1 minute time.
Good afternoon, everyone. I think since maybe to this year, this ferritin thing is coming up in a big way. 2-3 things what I believe we need to add, or maybe what is maybe our experience or my experience. See, it's HLH, any infection, not only viral, bacterial, even sepsis, anything can have can produce to HLH. That is one thing. Let's see in dengue patients. We don't believe they should have fever after 5th or 7th day, because that is the time they are like critical phase, fever should not be there. But still patient down the line on 5th or 6th day or 7th day presenting to you with a high grade fever with organ dysfunctions, you should think about HLH is a possibility. Believe me, in before last year also we have done, this year also we have done, the highest ferritin I have seen is 1,54,000 in one of the patients. These patients are really sick. They present with multiple organ dysfunction apart from this high ferritin levels. Now the question is, they are into a cytokine storm. They deteriorate very fast. So here there are few things. One is, let's say they are having some secondary sepsis. What we can prove with blood culture, and maybe the procalcitonin is high in those kind of situation. And now there is all the pictures fitting into HLH. In those kind of scene, anyway, we are treating the sepsis as effectively as possible. Now the one you just ask for the hematologist, they will be inclined towards starting some steroid or maybe some immunosuppression. These are the very difficult situation, what to do in those kind of situation. I think the best thing maybe is dexamethasone. The dose is 8 to 10 mg per meter square. We have tried in few cases, and few cases we have tried even plasma exchange, and few cases we have tried this hemoabsorption with different filters for sepsis. And believe me, the response was dramatic. You do a hemoabsorption with HA330 or something, the response with a 1 or 2 cycles of hemoabsorption is drastic. They will respond like anything. We are presenting few of our patients. Maybe we will be publishing those data. So this is little different. I think we cannot take it with a clearly like this is sepsis, HLH is not possible. We have to treat sepsis patient. Yes, you have to treat sepsis. In the meantime, if you believe there is a high probability of HLH, some form of immunosuppression they will require. If you are not able to give immunosuppression, maybe some form of hemoadsorption therapy will going to help them. This is what our experience over the last year and this year also. Lot of cases saved, what I strongly believe, because of immunosuppression therapy. If anyone else is having some experience, they can just put into this group. Will be helpful.
Yeah, Dr. Mishra, you are absolutely right. I agree with you that immunosuppression is mandatory because this much of ferritin is it's highly harmful and mortality is very high. So in this condition, immunosuppressants, antibiotic, along with that, because patient is in the cytokine storm, initially for to support, you can go for a plex. Then at the same time, simultaneously, you can consider for immunosuppressive effects.
Yeah, thank you. And this case which I presented turned out to be a Still's disease and is in the macrophage activation system. So started on steroids, and this patient recovered very faster. In 2 days, the patient recovered better. He's off NIV, off shock, and he became better. And I think in view of time, thank you. Thank you to organize the committee.
Thank you, Dr. Srinivas, for guiding us through this difficult interpretation. So, as a thank you from the IICCM Hyderabad, I would request Dr. Pawan Kumar sir to please come on stage and felicitate Dr. Srinivas Jakkinaboina sir. Now request Dr. Pawan to, oh, sorry. Yeah, now request Dr. Pawan to please felicitate Dr. Saroj Prushty sir. Thank you so much, sir. So now we close this session and we'll move on to the next section. I hand over it to Dr. Anand.